Good afternoon, everyone. Everyone's coming in. We're so happy to have you. So many familiar faces. This is going to be an excellent lunch and learn this afternoon. And we're talking today about our behavioral health justice fund legislation that was passed. I will turn it over here to my colleague Danny, who is going to get us started. I just want you all to know that there'll be more people coming into the room. So if you could just make sure that you're on mute, that would be very helpful to get us started.
Yeah. Thank you, Algeria, and welcome everyone. And thank you for attending today's Lunch and Learn entitled Behavioral Health and Criminal Justice Diversion, hosted by the National Association of Social Workers, Michigan chapter, and the Michigan Collaborative to End Mass Incarceration, also known as MySEMI. My name is Daniel Jones. I am the Outreach and Engagement Coordinator for MySEMI, and I will also be your moderator for today's Lunch and Learn. For those of you who may not know MySEMI is a broad-based, statewide, nonpartisan collaboration representing nonprofit, faith-based, advocacy, grassroots, and service organizations united to end mass incarceration in the state of Michigan. MySEMI's efforts to end mass incarceration include front-end diversion and alternatives to incarceration, which brings us to the purpose of today's presentation. We have with us today Algeria Wilson of NASW and Erika Parks of Pew Charitable Trust, who will share with you information on pending legislation and what it intends to do, available funding, and how that funding can be utilized to support diversion. If at any time you have questions during this Lunch and Learn, please utilize the chat box and we will attempt to answer your questions to the best of our ability. And now, please allow me to introduce today's presenters. Algeria Wilson serves as the Director of Public Policy for the National Association of Social Workers, Michigan chapter. In her role, she is responsible for engaging membership, various governmental agencies, and advocacy partners to implement state-level public policy that is in alignment with the Code of Ethics and Social Work values on behalf of the 28,000 plus professional social workers and the 6,500 incoming professionals across the state. Algeria is certified by the University of Connecticut's Nancy M. Humphreys Campaign School for Political Social Workers, which teaches social workers to run compelling campaigns and has received the Cine Jomo Award from the National Association of Black Social Workers for her commitment to policy work. Please welcome Algeria Wilson. We also have with us Erika Parks, who is a principal policy associate at the Pew Charitable Trust Public Safety Performance Project. While at Pew, she has served as staff to the Michigan Jails Task Force, helping a bipartisan group of state and county leaders analyze data, develop policy solutions, and pass legislation to safely reduce the number of people held in Michigan's county jails. Prior to her work at Pew, Erika received her master's degree in public policy and did research and policy work related to criminal and juvenile justice at the Texas Juvenile Justice Department and the Urban Institute. Please welcome Erika Parks. At this time, I will turn it over to Algeria and Erika for their presentation. Thank you.
Thank you, Danny. Thank you for such a warm introduction. I appreciate it, and I'm sure Erika does as well. I'm going to go ahead and get us started today. I have a few housekeeping reminders for today, as well as just some save the dates that I'd like to share with you all. So as my screen loads here. All right, so NASW, we've been very busy trying to just tackle all things related to social injustice over the past couple of years, especially as it relates to racial justice. And through this effort, we formulated our Social Justice and Anti-Racism Committee. These were some of our dates from 2021, and we'll be uploading our calendar for 2022 onto our website. but we'll still meet the second Tuesday of each month from 5:30 to 7 o'clock. We'll also have our virtual career fair coming up. We know workforce is a huge issue. We're trying to get as many social workers into the field as possible. So if you know a social worker that's looking for a job, or if you are a social worker that's looking for a job, please come out to our virtual career fair January 26th from 10 to 4 a.m. More information is on our website about that. We also have our social work exam institute, or Michigan Licensure Exam Institute. That'll be Friday, January 28th. It's for students and anyone who's trying to pass their exam. We'll have 2 conferences this year that we're very excited about. The Business of Social Work Conference, which really covers everything macro to clinical, anything that you can think of as it relates to how to work on the administrative side of social work. It'll be a very enriching conference. And then we'll also have a conference addressing implicit bias and racism in social work. You'll be able to get those implicit bias CEs that are required as well by the state now. So save the date for those. And backed by popular demand is our clinical concerns and gender identity training for mental health professionals. It'll take place February 25th and 26th. It's more information on our website. It really helps to educate mental health professionals on how to work with our transgender and non-conforming and gender non-conforming community. So please, if that's of interest to you, take a look at our website. We'd love to have you there. So again, today, I think many of us, we've been in the Zoom space for a long time, so housekeeping shouldn't be too difficult. We just ask that you stay on mute. We will have a section today for questions during the webinar, but if some questions come up in the meantime, please feel free to put them in the chat, and we will try and get to them as we go throughout our presentation today. Please feel free to keep your cameras on if you like to have your cameras on. If not, you can keep those cameras off. CEs, many of you are here for CEs today. You will receive your continuing education 1 CE hour today. That'll be mailed out to you, I believe, within the next 30 days for your session today. And that'll come from our administrative assistant, Samantha Grove. So if you have any questions about that, please do reach out to us, but you definitely will get that if you're a member, or if you signed up and paid today if you're not a member. Okay, so let's get started. We're here today to talk about our Behavioral Health Justice Fund, and really how we got to this point where we were able to have such amazing legislation pass through the Senate and the House and become signed into law. So there was some research that was coming to be done here in the state of Michigan. And we noticed that, there were some issues with incarceration, high incarceration rates, and Pew Charitable Trust came in to do some research to really see who was in our jails, what was causing long pretrial stays, high bail rates, and things of the sort. And so under Lieutenant Governor Gilchrist, he formulated a jail and pretrial task force. And there were many individuals on this task force to look at causes of incarceration in our jails. And what we noticed is, we needed someone there to also look at mental health and mental illness. And so through research, they were able to identify that within our jails, 1 in 4 individuals were experiencing some form of serious mental illness. So that right there showed us that, we needed to be doing more sooner. Because if there are 1 in 4 individuals in our jails experiencing mental illness, could there have been an intervention that took place sooner? But specifically in our rural counties, where our community-based services are scarce, and we don't have as many services as we do in like Metro Detroit area, we noticed that there were 1 in 3 people who are in our jails who are experiencing serious mental illness. We know that once an individual goes into our jails, it has some serious impacts, not only just on them and their lives, but also their families' lives. It can completely destabilize them. It can create, areas of recidivism where they're reoffending or going back into our jails. And so, again, what can we do on the front end to make sure people are getting the services and supports they need? They're not going into our jails, and that when they are exiting, they are experiencing a more stable lifestyle. We noticed through the research that those who had serious mental illness and or a substance use disorder, and sometimes both, they were staying longer in our jails than other populations. Um, that overall, individuals who have serious mental illness or substance use disorders, they're really dependent on law enforcement to be their first front line of defense in order to get them the services that they need. And that's expensive, and that's just not something that is efficient in the end. You should be able to get mental health care. You should be able to get access to inpatient or outpatient services, and your first response to help should not be being arrested. So ultimately, we knew that we needed to amp up some of our services that existed in Michigan, and create opportunities for funding to do more. And so in Michigan, we have community mobile crisis response teams, our community mobile crisis response services. They weren't new. However, there were some capacity issues. They weren't everywhere. The ones that existed, they could only service a certain amount of individuals. They may take people to a crisis center, but maybe there weren't enough crisis centers across the state or within that area to be able to get them to. And then overall, there was just some just limitations for being able to deliver the best care services with the current mobile crisis system that was set up. So we needed to expand and put in place a stronger model. And SAMSA recently released their best practice guidelines for crisis response. And so it was an effort to launch their 988 suicide hotline and have it in place across all the states. And they had guidelines on what needs to happen from the moment someone calls a crisis line or calls 911 all the way up into the supports and services they receive and follow-up care they receive. And so as we thought about mobile crisis response teams, we knew that we needed to have a linkage to align with what else was going on in the state as related to crisis stabilization, but also the guidelines that were coming from SAMSA. So the way in which the community mobile crisis services would operate is that you're in a crisis, you call 911, or you will call the MyCal crisis hotline, and dispatch would determine who needs to come. Is it law enforcement? Is it a community-based mobile crisis team, which consists of a clinician, so a social worker or a LPC, a peer recovery support specialist, someone with lived experience, and a law enforcement officer? Or would it just be that team in lieu of that law enforcement officer? In rural spaces, you have to get very creative. So there's opportunity to use telehealth responder. So maybe that clinician or that peer is on an iPad, but they're still there in some capacity. But ultimately, that mobile crisis response team is tasked with being able to de-escalate, to be able to provide an assessment or screening of the individual's current mental state, help them by referring them to the needed treatment and services that they need. And the law enforcement officer is there strictly to just maintain safety, to help de-escalate, if they can, as they can, enforce a law if they need to enforce a law, and really do some of that transportation if it's needed to the next space that the individual needs to go to. So if they need to go somewhere, we're looking at, are we taking them to a crisis center, a crisis hub? Are we taking them to an emergency room? Are we taking them to get an assessment so they can go to inpatient psychiatric care? Um, and so it's the call, it's the response, it's taking that individual to somewhere so they can be stabilized. But then also later down the road, it's ensuring that they have access to the mental health or behavioral health services they need, any homeless services that they may need, or healthcare services, etc. Because we want to be able to stop that door, um, and have them no longer have reduced just law enforcement encounters in general. And we know we can do that if we focus on getting people what they need. So deflecting them from running into law enforcement in the beginning. I see there are some chats, questions in the chat. I'm not able to see those. So Danielle, if at any point there's a question, just let me know and I'll um, take a pause. So crisis response, it's not new, but given COVID and everything that's happened, especially with brutal police encounters um, over the past couple of years, several years, we know it is more and more important to show up as social workers into this space. And it's a part of our social justice values, a part of our code of ethics, to really show up and engage in crisis response. Um, we have a commitment to our clients, to promote their well-being, to know what's best for them, or to work on behalf of them. And if we know that an individual needs substance use disorder services, or maybe they need some mental health care, it's better that we advocate to get them the services they need versus going into our jails. Referral to services. It's our duty to make sure that we are referring our clients or referring individuals to specialized knowledge and expertise. They deserve that. And our jails serve a purpose, but they're not going to fully serve the purpose in the early interventions and provide the early interventions that clients need. Again, as we went along this process of drafting legislation, and Erica will talk a little bit more about this here in a moment, and asking for funding, we really called on our membership, called on social workers to help us with this process. And it's really about our code of ethics as it relates to engaging in social and political action and our public participation. You really are responsible for helping shape policies, reshaping institutions. We had so many conversations around criminal justice reform versus abolition, especially as we went along this process. But as social workers, it's your responsibility to engage, because these also are emergencies that individuals are experiencing. So again, as crisis response grows in Michigan and across the US, just know that social workers always have a duty to be at the table, helping to make those situations happen, making those reforms and those changes happen. So a little bit more about co-response and mobile crisis. I'll turn that over to you, Erica, to take over.
You can go ahead and do this slide if you want, Algeria.
Okay, awesome. So as I mentioned, mobile crisis and co-response, they're not new. They are different. So I'll start there. We all need to there's a lot of confusion around common language. And so we're hoping that through our process, we can start to facilitate proper language around terms. Co-response is mobile crisis and law enforcement coming out together pretty much all the time. It's a law enforcement officer and a clinician coming out and responding. A mobile crisis team is a team of clinicians, peers, lived experience, and professionals coming out to assist. And law enforcement is only there when needed. So it's not necessarily always that joint connection. And they're meeting people where they are. And the response is really care, to provide services and supports and care. So there are other models that exist out there across the nation. Mostly known is Cahoots, the Cahoots model in Eugene, Oregon. They saw that theirs is more of a co-response model. And they did see that when they had someone who was not a police officer come out to a scene, it really decreased the burden on law enforcement officers by 5 to 8%. They started to see, you know, less calls for nonviolent encounters. And so that was something that really has appealed to the law enforcement profession, is they notice that they're coming out to calls consistently that aren't, you know, required of them, because they're more mental health calls versus calls that are really around, you know, violent encounters. And so being able to have someone else who is more skilled at that has really helped, you know, get law enforcement officers on board with this issue. They also noticed that mobile crisis teams, when they come out, they're able to link twice as many people to mental health care in the weeks following the crisis compared to traditional law enforcement response. So traditional law enforcement responses, there's a crisis, let's go to the scene, pick this individual up, take them to emergency room departments or emergency rooms. Sometimes those individuals stay in an emergency room, you know, for that night, sometimes up to 72 hours, but then they're back out, you know, into their environment. And did they have the proper follow-up care after they left? Were they linked with outpatient treatment? Were they linked with an appointment to the doctor's office? And through mobile crisis teams, they've been able to see an increase in those services. So it also noticed that having mobile crisis team services created 23% cheaper on cost per case basis than traditional law enforcement response. So responding, utilizing law enforcement response dollars to come out to mental health crisis was expensive. Crises was expensive, whereas having a mobile crisis team really helped reduce some of those costs. So just a little facts on this. I believe too, once you are done with today, you'll receive some of these slides so you can go back and review.
All right. Thank you, Algeria, and thank you all for inviting me to participate in this webinar. So with all of that great background on behavioral health diversion and crisis response, I'm going to get a little bit more specific and talk about the effort that my organization worked on in partnership with NASW and a bunch of other groups as part of the Michigan Jails Task Force that Algeria mentioned. So this effort that led to the two bills that got passed at the end of last year and the budget allocation that I'll talk about in a moment really started, several years ago, and there were kind of two separate efforts going on. So the Michigan Jails Task Force, as Danny mentioned in his introduction, was a bipartisan group of state and county leaders that came together to look at who was coming into Michigan's jails, how long they were staying, for what reasons. And my organization provided staffing and technical assistance to that group. And basically what they found was that there were a whole bunch of different drivers for Michigan's jails. And, many people think about jails as a place to hold people either sentenced to short sentences or being held pre-trial who are potentially a danger to the community. But probably unsurprisingly to a lot of you, Michigan's jails were being used for a whole bunch of other purposes. And probably the number one thing that we heard about from folks, both individuals impacted by the system as well as sheriffs and other stakeholders within the system, were that so many people coming into jails were there for behavioral health challenges. So that was a key finding of the task force, and the recommendation that they made, along with a whole bunch of other recommendations that sort of tangentially affect that issue, but are designed together to reduce Michigan's jail populations. One of the behavioral health specific findings was to invest state resources into alternatives, because particularly in smaller communities and rural areas, a lot of folks that we heard from said that if law enforcement runs into somebody in crisis, they don't really feel like they have an alternative besides taking that person to jail or maybe to the emergency room. So that was something that we were kind of working on as we worked to turn the task force's recommendations into legislation. And we got partnered up with the National Association of Social Work, who had also been working on a behavioral health effort that was originally about police and social worker partnerships and kind of evolved over time. So it was sort of a joint effort in partnership with Americans for Prosperity and the Michigan Association of Community Mental Health Association and Fountain House Clubhouse, to sort of build on both of those existing efforts and come up with a legislative push that we felt like we could actually pass and we could actually get some funding to address this issue. So, I think I personally don't have specific direct expertise on behavioral health, but I have a lot of expertise, in legislative drafting and working with the legislature. Americans for Prosperity brought kind of a conservative cred to talk with conservative lawmakers and bring them on board. They had done a bunch of work on, getting examples from other places about programs that were working. Obviously, Algeria and her team brought, the direct social worker experience. We had the perspective of folks with lived experience from Fountain House Clubhouse. And it was really bringing together all of those diverse perspectives, I think, that helped us come up with, legislation that really included all of the key components for sort of guiding good diversion programs and crisis response programs, as well as putting together something that could actually pass through the legislature. I'll come back to these kind of strategy pieces, but maybe if we go to the next slide, I can tell you sort of exactly what we're talking about here. In coordination with a bunch of other mental health things that are going on, that Algeria touched on some of them about, like the crisis, MyCal and the crisis line, and many other kind of mental health and behavioral health initiatives. This specific project was about creating a behavioral health grant program and kind of putting guidelines in place for localities to apply for the grant program and to either create or expand mobile crisis response in their jurisdictions, or behavioral health diversion from jail more generally. So we had a $5 million that were approved by the budget that are kind of out there ready to be spent. And as the legislature is working on its supplemental budget this year, there's $15 million more that the Senate has kind of approved and that the House will need to approve to expand that grant program and be able to serve more communities. So because this was a joint effort, we ended up with half of that funding going towards community mobile crisis response. And then the other half is focused specifically on rural counties because of that disparity that Algeria mentioned up front about those rural places having fewer resources. They may not have, the resources to put in place a full crisis response team, but we wanted them to be able to still be eligible for funding to try to divert folks with behavioral health challenges out of their jail and get them into other kinds of care. So this, besides the budget ask, was two pieces of legislation sponsored by Senator Stephanie Chang and Senator Rick Outman. So it was a bipartisan effort. And it's one grant fund that has those two pieces, and each of them have the legislation kind of lays out the structure for the grant program, some of the metrics for outcomes that Algeria will talk about in a little bit, and you know, who's eligible to apply, sort of what the process is. So the grant fund is housed within Michigan's Department of Health and Human Services. That was really important to folks involved to make sure that it was a health program and not, you know, within the criminal justice system, since the goal is really diverting people out away from law enforcement and away from jails. So as we were, you know, working through the strategy of this, I kind of mentioned this, but you know, especially when you're talking to legislatures, particularly if you're trying to convince them to fund something, there's a lot of questions. Pretty much everyone we spoke to recognized that mental health was a big issue in Michigan, that particularly using jails to address mental health challenges is not efficient, it's not cost effective, it's dangerous, it's not appropriate for folks. So there was a lot of buy-in for that, and using some of those stats and examples from other places that Algeria mentioned, we were able to kind of convince them that this was an alternative that could work, that putting funding towards it was an important piece. And, you know, we used different messengers. We used law enforcement as messengers in a couple of places, saying, you know, we don't want people with behavioral health challenges in our jail. We're not equipped to deal with that. We know it's not the best place for them, but we just don't have alternative resources. We used Americans for Prosperity as a kind of credible conservative messenger, and we're able to pass these bills with almost unanimous support in both the Senate and the House.
And then if I could add, Erika, too, we also worked with our partners at the Center on Behavioral Health and Justice, which many of you on this call probably know because they're made up of pretty much all social workers, but their research and knowledge, especially around crisis response and deflection and diversion, really helped also add more credibility to this initiative. It really helped just move it forwards greatly. So I just wanted to make sure I gave them credit where credit's due.
Yeah, absolutely. And Dr. Cheryl Kubiak was on the jails task force. So she brought her kind of wealth of knowledge about that to the task force and was really instrumental in making sure that they focused on the behavioral health piece of things also. So this is kind of, for the community crisis response piece, this is sort of a you know, pretty basic flow chart of how it's designed to work. So Algeria talked a bunch about the difference between co-response and crisis response. And this was something that a lot of diverse voices in the coalition wanted to be sure that we didn't limit it to co-response only. So, you know, because law enforcement currently are often the responders to these kinds of calls, the legislation is structured to require that law enforcement communicate and coordinate with any mobile crisis response team that's initiated. So they sort of know who's responding to what kind of call and can decide what the best process for their community is. So basically, if a call comes in about somebody reporting a behavioral health crisis, based on, you know, what kind of call, the circumstances, and what the teams have decided in advance, it'll be either, you know, just clinicians and peer support specialists who respond, or maybe law enforcement will respond in coordination also. Upon responding to the incident, the goal is, you know, immediately evaluating the situation, de-escalating, determining what the person needs in that moment. There is still, you know, the potential that if somebody has committed a crime or there is actual danger present, you know, there's still the ability that somebody could potentially go to jail. But the goal is to prioritize other kinds of treatment, whether it's a crisis drop-off center, a pre-admission screening unit, or just referring the person or handing them off to outpatient behavioral or social support services. So I'll hand it back to Algeria to kind of talk about the metrics that are in the legislation and the outcomes that we're hoping will be achieved.
Yeah, thank you. So as I mentioned before, other states, they've tried to, launch a like-minded program. And what we noticed when we were trying to look across states to just get information on, did that program work? Was it efficient? etc. The metrics were limited. So we knew that in order to, have a strong model, or to have a model in general, we needed to evaluate it. We needed to make sure that we were able to say whether or not this program is working, is it saving dollars, are people getting the services that they need? I do want to back up just to mention that what is really unique about this community mobile crisis response portion of the legislation um, is that even though we have listed social workers and peers, et cetera, as a team and a unit, we don't have that team and unit being embedded into law enforcement departments. And we were very intentional about that because we know that social workers, we have a certain code of ethics that we adhere to, and we don't want by any means to dilute our profession. We want to make sure that we continue to stand alone as a profession, but work in coordination and lead and be the pioneers in this space. And so a part of this program is to have those teams, to have a memorandum of understanding with a law enforcement agency, but they're not going to have an office embedded into a department. And so for the mobile crisis response piece, what we're looking at is for the number of calls that were transferred for telehealth, was there a physical response follow-up? So did somebody actually come out to that call after that telehealth visit? For the community crisis response team, how long were they on that scene? Was it 10 minutes? Was it an hour? How long did it take for that team to come out and spend time while there? We want to know about the demographics of the clients who are served or people who are responded to. We want to know if the calls resulted in a jail admission. Was there on location de-escalation? What type of services were provided? Was it crisis stabilization, community-based services? Was there an inpatient admission to a behavioral health facility? Was there a referral to inpatient or outpatient mental health or behavioral health services? Did we do a referral to community-based services, such as, a homeless shelter, a women's shelter, food pantries, etc.? And these are not limited to what we have listed here, but those are some of the metrics that are important to gather. Did this reduce the frequency in law enforcement interaction, especially with those who are known to be served? So our friendly faces. Did law enforcement, not come out as much? What was, as it relates to the number of follow-up visits, what's the method and location? Was a follow-up, a telehealth visit? Was a follow-up, again, somewhere off-site? How often, etc.? What's most important, or not what's most important, a factor that is very important is the cost. So we need to know what's the cost administratively, training-wise, and then also those crisis response teams. So we know the teams will need training. We know the law enforcement might need training. We know there's going to be some type of administrative overhead, supervision, etc., that comes in with that. And so we really need to be able to have the metrics show us cost. Also, breaking that down into, per call cost, etc. Those are some of the metrics. Those aren't all the metrics, but we're hoping that the metrics will tell a story that will help us keep our program going, or will help us improve our program and just strengthen it as we go throughout the years here in Michigan. So outcome-wise, there are immediate outcomes that we like to see. And those immediate outcomes, we'd hope to gain some long-term impacts later down the road. So immediately, we want to reduce arrest. Um, we want to reduce those emergency room department intakes, especially with COVID. Um, we just want to make sure that people are getting to the places that they need to be. Um, we want to increase the connection to treatment and services, reduce those repeated crisis related calls, reduce the use of force. We want to improve responder awareness for those who have serious mental illness and substance use disorder issues. Um, some counties have done really great with, you know, being aware of those individuals in their community who might have some challenges. But we want to expand that knowledge with this program. And we want to improve the client's experience and their relationship experiences um, to their treatment, to community supports and treatment service providers, but also with law enforcement. Um, those are some of the immediate outcomes. Long term, overall, we want to really just reduce reliance on systems that are not designed to deal with those with specialized behavioral health issues, which is law enforcement. We want to reduce reliance on law enforcement. We want to save. Uh, incarceration is very expensive. Um, and so putting more money on the front end for mental health services can do a lot. Reduce instances of substance misuse. When speaking with some of our Republican leaders in the state, um, one area that really got them on board with this beyond cost was the issue of substance use disorder or substance misuse in their counties. Overdose rates and things of the sort, they were just seeing it everywhere, specifically as it related to meth use and more. So it was just a given that they wanted to be able to assist in with this process. So I think that speaks volumes of um, just the challenges that exist across the state, and also how much more we need to really do to focus on providing just better treatment and care, better treatment and care. Again, reduce number of initial jail visits and reduce recidivism. So there's a model out there called the Sequential Intercept model. Some of you are probably familiar with this. It's a guide that talks about how to reduce contact with law enforcement, all the way up to how to reduce recidivism. And there are different steps along the process from 0 to 5. And we're really still working in that step 1 area where we're step 0 to step 1 area where we're trying to reduce that encounter, which we refer to as deflection. Diversion is diverting people out of our jails, and deflection is keeping people deflected from law enforcement in that initial encounter. So we aligned sequential intercept model step 0/1 to SAMSA's national guidelines for behavioral health crisis care. And these are just some of the steps, again, that align with those processes. That you'll receive some of this information again at the end in your email, your follow-up email. So while this is a great initiative, there's still so much that's needed. It's not perfect. And I'm sure today we made these slides a while ago, and I'm sure we could probably add some more to this. First, we need specialized dispatch training. I think there's some things coming down the pipeline on the federal level to ensure some type of standardized dispatch training. We need to increase our behavioral health workforce. NASW is going to be doing a lot on this workforce for 2022 moving forwards, because we can't respond if we don't have people to help respond. We need additional funding for inpatient psychiatric care. We need additional beds. We need more staff there. We need national standardized police data collection. If we want to see what's going on in Macomb County and Ingham County and, you name it, we need to be able to look at the data, look at all the same data points to see what are the challenges. There are some cool, interesting data hubs now that are out there. I know the Center on Behavioral Health and Justice has a nice new data dashboard to look at different points of care for individual. But police data collection, we need a more standardized approach, even for mobile crisis. So we're setting a groundwork here to say we want to collect these metrics so we can evaluate the program. But if they go to set up a program, in Virginia or in, Oklahoma, are we all looking at some of those same data points, et cetera? So that's what I mean when I have that there. Standardized language for crisis response programs. So what does it mean for co-response? What does it mean for mobile crisis teams? What is deflection? What is diversion? That common language is important. We need to continue to increase behavioral health emergency funding that coincides with our movement for non-police emergency response services. So I mean that on a federal level to a state level. I think what we're seeing now is great. There's a lot of federal funding that has come in through ARPA, which is how we've been able to really help fund our initiative, because on a federal level, they've put forth 988, as a model and funding for 988. They're recognizing workforce. They're recognizing community mobile crisis response teams. So we really try to align our language with the federal language to get those dollars. But we need to keep this as an ongoing need, because 1 to 3 years isn't going to solve an issue. It's going to get us started on the right path, but we need a commitment to continue to fund strong programs like this. Again, data cohesion across counties, 24/7, 365 crisis stabilization services, expanded GPS technology services. So if we're in the UP and they need to have a telehealth provider on an iPad, do they even have the technology and the services to be able to do that, to have quick crisis calls, to have quick dispatch services? So technology is so important, and we need to try to find ways to expand access to that as well. Continued stakeholder collaboration still needed, from those who are working on the ground, delivering the services, to those who are, at DHHS administering funding. So continued communication. Crisis response coding. I was on a call a couple weeks ago, and I believe there are some efforts coming soon to try and bring about some coding for crisis response services. So hopefully some of these things that are still needed will happen, but it's going to take some time. So again, just some additional principles. Social workers, again, should maintain a clear separation from law enforcement by resisting being embedded as a direct employee of law enforcement agencies. Again, it's just because our values are different. We know there's law enforcement who too cares about their community. We're not saying they don't, but they do serve a different function than social work services. Law enforcement is more responding to violent encounters. Social work is more of strengths-based, putting the client and their needs first, and providing them the supports and services they need. To be able to combine those two spaces can create ethical dilemmas. We've even heard some things from law enforcement about liability, making sure that, if a social worker was embedded into a law enforcement department, who would be liable for something going wrong. And so we carry with us a lot of knowledge and expertise. And so again, just making sure there's that clear separation is important. And then again, just social work crisis providers are ideal members of our communities. They're ideal members of our community-based crisis response systems. And we can continue to work in collaboration and co-respond, but just continue to maintain our identity as a profession. So what can we do next? We have the money. We have some money, we don't have all our money. And so we need to do more in order to strengthen this program. So we just want to encourage you today, as the funding becomes available, there are going to be some RFPs being released by the Department of Health and Human Services over the next few months. NASW will keep the community, our social workers, aware once those proposals come out. You will have to meet the criteria. It'll be laid out in the RFP. And so we'd encourage your communities to apply to have more mobile crisis units or to strengthen your mobile crisis unit. But we also want you to encourage the House to add the additional $15 million to the jail diversion fund. There's $5 million now, 2.5 for jail diversion, 2.5 for mobile crisis, but we can do so much more if we have the additional 15 million. So on the screen there are some contacts. Representative Whiteford, who's our appropriations chair for the House Health and Human Services, Representative Albert, and then Representative Wentworth. So please, again, we always ask you to take away some things. Please assist us in getting more funding for this program. So I will provide our contact information here. I think we're going to go into some questions. I'm going to stop sharing my screen so I can see your chats and your faces. All right, I'll turn over to you, Danny, for Q&A.
Yeah, and thank you, Algeria, and thank you, Erika, for this very informative lunch and learn. There were definitely several questions placed in the chat box, and thank you to everyone who answered some of those questions in the chat box. The first question is, with decarceration due to COVID, how many of this SMI population was just let out of jail or prison with no discharge planning or warm handoff?
That's a great question. We don't have data for that. That's a really great question. I mean, I'd imagine that those numbers would be high. And so it just goes to show how much more work that we need to do. And you think about those who are exiting our jails, needing to go home, where they also connect to services and supports that they need. So that would be some interesting data to look at.
Definitely. And if I may, I know of one person who was released early from prison due to COVID, and he was given no additional supports or any re-entry protocols were put into place. He was rushed through parole just to be released. But due to supports, on his behalf, he's been able to adjust well and is doing great, but really no support or help from the MDLC. Thank you. That was a great question. Our next question is, where do the funds come from for the crisis team?
So it's a part of the package. So again, the legislation was called the Jail Diversion Fund. And so half of the funding that we've received would go towards other jail diversion efforts in rural spaces, other jail diversion efforts and in those spaces and diversion efforts in rural spaces, I apologize. And the other half is for community mobile crisis response. So when I say other jail diversion efforts, that means victim services. That means a wide variety of program programs that could help with diversion. It's very broad. That portion of the funding isn't defined, but the mobile crisis funding has more criteria behind it. Sorry, I'm looking at the chat too as you talk. There's a lot of comments.
Yeah.
Sorry if we don't get to all of them.
Yeah. So, I hope that answered the question. And the next question is any of this going on in the Upper Peninsula that you are aware of, county specific?
Erika, do you know that question? I know there are some efforts in the UP because they are using telehealth services right now. They are using iPads. I'm not sure what the counties are. I know they just set up the MI Guidelines up there. Did you have any data?
I was just looking at some information from the Center for Behavioral Health and Justice, and it looks like Marquette County might be the only one in the UP who has some form of mobile crisis response right now. It's definitely, the area of the state where those kinds of resources are lacking the most.
Mm-hmm. It's also a workforce challenge issue. We need more social workers in the UP. We need creative ways to attract talent to go up there. So we have more supports and services and better response up there. So I'm hoping through, the jail diversion fund here and money that's coming in our efforts to work on workforce that we'll have more talent in the UP soon.
Okay, thank you. Our next question is, how is it determined that a mobile crisis team is called to a scene versus law enforcement being the lead?
So that's definitely dispatch. That's where that specialized dispatch training is needed, or it's going to happen. So it's dispatch that will determine which team needs to come out. And so dispatch plays a critical role in this process. I believe Danielle also placed in the chat just a link to one of our recent social justice briefs on this topic that talks about the need for specialized dispatch training. And so if you'd like to read more about different components of this crisis response system, please feel free to take a read at that document.
And I'll also just add that that's also where the memorandum of understanding between law enforcement and the community provider that Algeria mentioned comes into play, that those groups should have a conversation about it beforehand, what types of situations they want to send different response teams to. And
I do want to respond. There was one, there's been a couple of messages in the chat about embedded social workers. So we know that quite a few counties have began to hire social workers and embed them into their teams. We wish that these law enforcement agencies would have reached out to NASW to partner with us to learn about what we were working on, and just even nationally, the stance on social workers being embedded into law enforcement departments. It's happened, and if that works best for that community, that's what works best for that community. But we've seen huge capacity issues. We've seen that because there isn't like a best practice standards yet for a social worker working inside of a law enforcement department, that law enforcement kind of has a say on what that social worker does. So we've seen social workers, just being used as referrals to services versus actually responding. We've seen high burnout rates because they're responding everywhere within their county, and just it's not safe on the well-being of the social worker in some cases. And we're not saying all law enforcement agencies utilize a social worker like this, but there are reasons why we advocate for better care for our social workers. So I just wanted to address that.
And I see that it is now 1 o'clock, but we only have like a couple of questions left. Should I ask the questions?
Yeah, I think that's fine. And for those who can stay, please stay. And if you have to go, we thank you for joining us, and you'll receive your CE.
Yeah, and it's just a couple of questions left. And I think this one may have been answered in the chat box already. But the question is there a difference between co-responding and a mobile crisis team?
Yes. So co-response is that law enforcement officer and social worker or clinician coming out together. A lot of times in co-response situations, you'll see a clinician in law enforcement uniform gear. And mobile crisis is a team of clinicians. So a clinician, a peer, sometimes a person with lived experience, and they come out either in lieu of law enforcement or with law enforcement, but law enforcement is only there as they need to be. Oftentimes they're, down the street. They let mobile crisis come in and meet the person where they're at doing what they're doing. And so some successful models in the state that have this model is Network 180 in Kent County. There's Common Ground. They do a lot of crisis response services. So really being able to expand programs like that operate in that way. Network 180, they even work with their fire department, which is interesting. So yeah, I see Renee saying we do too. So yeah, as you see, it's growing and expanding.
Oh, thank you. And I believe our final question is, what is an outpatient behavioral health service? Is that community health?
So outpatient is, so say you have some substance use challenges and you need to see your outpatient use disorder provider. So you would go to an outpatient clinic to talk to someone versus inpatient where you're housed for X amount of days. So
I just have one question. What does SMI mean?
serious mental illness.
Okay.
And I did see one final question, which says, I am semi-retired. However, I might be willing to provide emergency support. How will LMSWs get trained for this?
So training is going to be one of the next steps in the pipeline. And I'm not sure who will be providing that training, but we know it's needed. We can't just provide the funding and not have the training. So that'll be coming down the pipeline too. Hopefully if you are retired, you'll be able to get back into the workforce and attend some trainings to be able to do some of this care. A lot of these providers will probably come from the community mental health agencies. And so they'll have some specialized training as well because they do some of this already. So that will probably be, my first thought as to who will be trained first and where that training will exist initially.
Yeah, thank you. And if there are no further questions, definitely would like to thank everyone who attended today's Lunch and Learn. Special thank you to Algeria Wilson, Erika Parks, NASW, Pew Charitable Trust for all of your amazing work around this issue. In closing, I ask that you check out MySemi's website. Please join us. You can join us by simply signing on to MySemi's resolution, which will automatically get you a subscription to our monthly newsletter, get up to date on everything MySemi. You can also follow us on social media, visit our YouTube channel, and hit the like button. Also, please join the Michigan Collaborative to End Mass Incarceration for a panel discussion on Tuesday, February 8th for our webinar entitled Restorative Justice as Diversion. That will be at noon. You won't want to miss it. Happy New Year. Please get involved, stay informed. Have a blessed Tuesday. Peace and love. Thank you for joining us.